Hello and welcome to today's webinar, Quality Decoded, CMS Final Rule. I'm Cassie Yazzo, Senior Product Marketing Director here at Cotiviti. Thank you so much for joining us today. During our presentation, you may click the Questions tab at any time and submit any questions you may have. We have a lot of material to cover live today, so your Cotiviti account team will follow up on any questions posed after the webinar. We do encourage you to submit your questions with your name visible to us and the anonymous option unchecked, so we know how to get in touch with a response to your question. With that, let me introduce our speaker today. Marge Ciancetta is the product manager of Cotiviti's Star Intelligence tool, which assists health plans to improve their quality ratings and star scores. Marge ensures that Star Intelligence represents the voice of Cotiviti's clients and aligns with industry best practices. With over a decade of experience in quality and Medicare Advantage star ratings, Marge has a unique perspective on the challenges and opportunities facing health plans and providers today. She works closely with our development team, as well as with customers and stakeholders, to ensure that their feedback is incorporated into the product roadmap. Today, during the third webinar of Cotiviti's year-long Quality Decoded webinar series, Marge will review with us the significant implications of CMS's final rule on the Medicare Advantage Star Ratings program. Each February, CMS draws attention by releasing an advance notice, which Marge talked to us about, outlining methodological changes for the Medicare Advantage and Part D star rating program. Following meticulous review and consideration of comments and inquiries, CMS then presents the final rule. This definitive document outlines confirmed measure and policy changes to revolutionize upcoming star ratings years. Marge will get us equipped to navigate through these regulations and understand some key strategies to prioritize and prepare. Without further ado, let's turn it over to Marge. Marge?
Thank you, Cassie. It's great to see you all again today. Thank you so much for joining us. I'm just going to start with a little overview of the same timeline that we viewed during the advance notice presentation. So on January 1st of this year, CMS presented the advance notice, which outlined all of their methodological changes that they were proposing. Then the public had a month to comment and provide feedback back to CMS. And then finally on April 1st, the final rule was published. With that final rule, as Cassie said, all of those proposed changes were codified and now represents the future of stars as we know it today. So there were a lot of changes included in that. It was a 1,300-page document. We certainly can't cover all of it today. So I'm going to focus on the items that most closely affect the star ratings program. Okay. We'll go through all of the changes 1 year at a time, starting first with MY 2023, also known as Star Year 2025. I'll provide a quick summary of the changes that were previously codified, and then go through the rulings that were codified with this latest ruling. All right, starting with those previously codified changes, the first one was the increase of PCR from a 1x to a 3x. Breast cancer screening moved over to an ECDS measure, really kicking off the transition to digital measurement. We saw the optional exclusions are now required for several measures, which are listed here. For the Getting Appointments and Care Quickly measure, there was a removal of one of the questions pertaining to wait times. The Advanced Illness and Frailty exclusion was updated a bit. There were some changes to the value sets, and now also more than one code is required. And finally, the web survey mode was added to the CAHPS measures. Okay, so now focusing on the latest changes from the 2025 rule, there were 3 that pertain to measurement year 2023. The first one was the addition of the social needs screening and intervention measure to the display page, not part of the star ratings program, just on the display page. This reflects CMS's move towards that universal foundation of measurement, and we'll see a few more of those measures added in the upcoming years. There were some updates to how appeals rules are handled for quality bonus payments. Essentially, there's a lot of pieces to this, but the gist of it is that CMS set limits on what data could be challenged because some of that data has already been validated and signed off on by auditors. And also, it states that the burden of proof is on the MA organization to prove that there was an error made in the calculation of a quality bonus payment. And finally, this is more of a clarification. They codified that measures with substantive changes are treated as new measures and returned to star ratings as a 1x weight. Now, that was common practice already, no changes there. It just hadn't been codified. It was more of tribal knowledge. So that's now been finalized. So all of those changes to MY 2023 were non-substantive, which makes sense because the year is already pretty much over with those submissions coming up in June. So let's move into MY 2024. That's our proactive year that's currently in progress. So again, let's start off with the previously codified changes. First one was a big one. This was the reduction of the patient experience in complaint and access measures from a 4x to a 2x. So all those member experience type measures, there were 16 of them, had been worth a 4x weight. They have been reduced down to a 2x weight. Next, we saw the improving or maintaining mental health and improving or maintaining physical health measures come back. Those had been removed from star ratings during COVID due to some data integrity problems, right? They couldn't reliably collect all of that data. So now that COVID is over and we have our baseline again, those measures have returned to the program. Kidney health evaluations was added at a 1x. Colorectal cancer screening moved over to an ECDS measure. The breast cancer screening measure added some additional members to its denominator, looking at transgender and gender diverse members. For both the medication adherence and SUPD measures, CMS aligned their continuous enrollment criteria with PQA specifications. So before they had looked at enrollment on a monthly basis rather than seeing if you were enrolled for the year, and then they were applying member years. All of that has been moved out, and now the measure much more closely aligns with how PQA calculates it. SUPD, the age criteria was aligned with PQA specifications as well. For this measure, they were, again, like calculating SUPD's age on that monthly basis, but now they're switching over to the continuous enrollment on a yearly basis. The age is calculated on that yearly basis as well. Two more previously codified changes. The first one is the removal of the 60% rule for extreme and uncontrollable circumstances. They basically said now that two key outliers are in place, those extreme and uncontrollable circumstances are already accounted for. And the last thing we already knew was that the risk-adjusted med adherence measures were added to the display page starting with this year because they will become part of the star ratings program in MY 26. Okay, next up for MY 2024, let's go through the latest changes that were finalized with this rule. First, the continuous enrollment criteria was put in place for the additional measures that you see in that first box. So for polypharmacy CNS, polypharmacy ACH, and COB measures, just like those other PQA measures, CMS is aligning with the continuous enrollment criteria. For the additional Part D measures listed in block number 2, this is a non-substantial change where the source for the hospice and ESRD status is now going to come from the CME, Common Medicare Environment, instead of the Enrollment Database, EDB. So with that move, they are not expecting any big changes. The data is very tightly shared closely aligned with those two sources. So they don't expect any impacts to the measures there. For the measures that you see in the third block, right, FMC, a few diabetes measures, and for all of those measures, we are looking, NCQA is looking to enhance how they identify chronic conditions. So right now, there's different rules on how many events you need based on if it was an inpatient or an outpatient setting. So as NCQA makes that identification more consistent across measures, CMS will follow suit and do the same thing. They're also looking to bring in additional ways to identify those chronic conditions via clinical data. So for example, if there was an active diagnosis on a problem list, that would count as a diagnosis for a chronic condition as well. So again, we see that move towards digital measurement taking place slowly but surely. Finally, for MY 2024, there were 2 additional measures added to the display page. That's the DSF and AIS measures. Those are also part of the Universal Foundation of Measurement, and so we see CMS continue to align their measurement towards that goal. Okay, now let's move on to MY 2025, also known as Star Rating Year 2027. This is where we really saw the bulk of the changes that were announced and codified with this year. They're mostly reflected in this MY 2025 year. So, as expected, we already knew that the improving or maintaining mental health and improving or maintaining physical health measures would increase to a 3x. They were previously measured at a 3x weight before they had been removed due to COVID. So now they're back. They start off as a 1x weight and then increase to a 3x weight in 2025. Also, the biggest change by far, at least in my book, is the removal of the reward factor and the replacement with the Health Equity Index in 2027. So when it becomes part of the Star Ratings program in Star Rating Year 2027, it will use data from 2026 and 2027. So that means for this year, the year that's currently in progress, make sure that you are tracking your members with social risk factors and getting an idea of how your contract is performing in the Health Equity Index. Now moving on to the latest changes from the 2025 rule, you can see there are quite a few. So first, Care for Older Adults pain assessment is now retired officially. Care for Older Adults functional status assessment returns at a 1x weight in 2025. MedRec post-discharge had been counted as part of TRC, but also as a standalone measure for the last several years. They are finally retiring the standalone MedRec post-discharge measure. It will only now be tracked as part of the TRC measure. Colorectal cancer screening, that is expanding its age range. It will now include members 45 to 49, reflecting NCQA's increase of that age range. We also see the COB, concurrent use of opioids and benzodiazepines, that was added at a 1x weight, as was the polypharmacy ACH measure. The polypharmacy CNS measure was not brought into the program at this time. That had been deferred. For the SPC measure, there is now a statin intolerance exclusion. And then I thought this was an interesting one, the MTM program completion rate for CMR. So they're working on bringing in a new measure into the Star Ratings program in 2027. The current measure as it stands today will move to the display page for 2025 and 2026. They did confirm it will be considered a new measure when it comes back in 2027. So when it does, it will be considered a 1x weight. Additional changes from 2027. So AIS, we know, was just made part of the Universal Foundation, and so it's currently being measured. The NCQA is making some changes to this measure, so CMS will follow suit with those changes, including a lower denominator age range, the removal of the herpes zoster live vaccination indicator, and the addition of a Hep B vaccination. For diabetes eye exam, there were some additional numerator codes added. This is in preparation for the move to digital measurement, making it easier to capture those numerator codes digitally. There was no reference to the eye exam measure moving to an ECDS measure. I know that there had been some conversation about that, but per this ruling, there was no codification of that. Other things that were deferred include that hold harmless provision. So this had been proposed a few rules back where they proposed that the hold harmless provision only should apply to 5-star contracts, not 4 and 4.5-star contracts. There were no updates on that proposal codified in this ruling. There was also no updates on this next one, which is the guardrails for non-CAPS measures. They had proposed removing those guardrails, but that has been deferred. Finally, in the 2025 advance notice, CMS had suggested some updates to how timeliness is defined for appeals. Now that nearly almost all appeals are submitted electronically, that would have affected the plan makes timely decision about appeals, as well as the reviewing appeals decision measures. That has been deferred. Any changes they make will have to be introduced in future rulemaking. All right, and then the last year that we're going to cover as part of this section is MY 2026. Because it is further out, there aren't as many changes to review, so we'll just go through them quickly. For the med adherence measures, CMS had already identified that these measures will be moving to risk adjusted. So the non-risk adjusted measures will be retired in MY 2026. And the new risk-adjusted med adherence measures will be added to the program at a 1x weight, right? Any new measures coming back into the program come back at a 1x weight, but expect them to go right back to a 3x weight in the following year, MY 2027. CMS is also removing the inpatient settings and SNF stay adjustments to align with PQA specifications. So I know that had been a thorn in the side of many plans for many years now, tracking the measures slightly differently between CMS and PQA. So this is one more step towards alignment. Okay, and finally, codified changes from the 2025 rule. I listed both of these proposed changes as deferred. So we know that CMS wants to add this IOP measure to the program, and they do intend to do it, but as of now, the timing is unknown. I expect that this one will be added in a future ruling. And finally, breast cancer screening. NCQA has made significant changes to the breast cancer screening in the last few years, extending the age range. So that new extended age range is going to be added to the display page and will eventually take the place of the existing measure, right? They're considering it a new measure so they can add it to the display page while the old one still stays part of the Star Ratings program. When that happens is dependent on NCQA. So expect CMS to follow suit as that is moved into NCQA's program. All right, next steps. We went through quite a bit of data. Let's try and take a look at the bigger picture now, see how all of that comes together and figure out what our focus needs to be upcoming. So what you're looking at here is the contribution of each measure category towards the overall pie that is Star Ratings. So a 1x measure is like 1 slice of pie. A 3x measure weight is more like 3 slices of pie. And that pie has continued to shift over the last several years quite dramatically. At one point back in 2024, there were 108 total weights, or 108 slices of pie that made up the Star Ratings program. By 2028, it's down to 79. So every slice is worth more towards that overall. Let's start at the left with the caps and operations measures. Remember earlier we had said that many of those patient experience and complaints and access measures reduced from a 4x to a 2x. That's why we see those categories go down in their overall contribution. So they're still an important part of your star ratings program, right? Each coming in at 22 or 23%, but definitely worth less than they were before. So the slices of pie that went out of those categories increase the amount contributing to the other categories. Cost measures are making a steady increase over time. The reintroduction of the improving or maintaining mental health and physical health, those were added back in at a 1x and then increased to a 3x the following year. So that category as a whole is expanding and contributing more weight. CMS did mention that they might be adding a new activities of daily living measure, but nothing has been proposed yet. So at this time, the HOS category stabilizes at about 11%. The improvement measures are each weighted at 5x still, no changes there. So that total of 10x weight, because again, there are less slices of the pie, moves from about a 9% contribution to a 13% contribution. So continue to prioritize your improvement measures because they do significantly contribute to your overall contract weighting. Finally, let's take a look at the HEDIS and pharmacy measures. So a lot of the changes that we discussed today relate to these two categories. There were several measures retired, several new measures coming in. So it's kind of like a net change between those leaving and those coming into the program. So the overall weight didn't fluctuate too much due to the measures, more just that decrease in the caps and operations measures. If you look at the blue bar in pharmacy category, that's MY 2028. So that reduces to 8% in 2028 because those risk-adjusted med adherence measures come back at a 1x weight. But the measure contribution of that pharmacy category will pop right back up again when the measures increase from a 1x weight to a 3x weight in the following year. So don't take your foot off the gas when it comes to those measures. Okay, so we covered a lot of changes today. What should plans be doing to prepare? I really put this into two different categories. The first one was to analyze, and the second one was to take action. So we've seen a lot of historic shifts coming into place over the last several years, including Tukey outlier deletion, those measure weight changes, the removal of the reward factor, the addition of the health equity index, and now the move to ECDS measurement. So it's more important than ever before to start planning today for tomorrow's success. You can't assume that you're going to be able to keep doing things the same way as before, and you really need to take those steps today to set yourself up for success tomorrow. So a few things to analyze. When you look at your program, what does the removal of the reward factor do for your plan? Were you receiving the full bonus before and now you have to make up that difference somewhere else when that reward factor goes away? Think about what your expected HEI reward is going to be. Does your plan qualify for that? Are you going to go all in on the health equity and try and make sure that your rates help you achieve the maximum HEI reward, or are you going to look to make up that difference somewhere else? How are your rates for members with social risk factors, right? Plans haven't really had to focus on that as much before. So do you have all the pieces in place to be able to follow those members and see how they're performing in all of the different measures? And then just more generically, what are the effects of all of those measure additions, retirements, and weight changes? A lot of plans had heavily invested in those caps and HOS measures over the last several years. So when the weight of those measures was reduced, they don't contribute as much. And so plans aren't getting as much of a bump from their investment there. So where else do you make up that difference? And this is where I come to my optimized talking points. So I know we've said it before, I'll say it again. STARS is a big math problem, and you should be able to plot out that math and make sure you are working towards that plan all throughout the year. Make sure that you are tracking towards predicted cut points. I know a lot of plans were caught off guard last year by the Tukey outlier deletion going into effect. So I think we can all say confidently that our cut points continue to increase. And so tracking towards last year's published cut points can definitely leave you short. Make sure that you're improving and maximizing your improvement measures. So for each measure, the thresholds that you should really be thinking about are, can I achieve significant improvement or can I reach the next star? Know where those threshold points are for each measure so that you can set realistic goals for your plan. Measures don't have to increase by 5 or 10% every year. And actually, in the long run, you will hurt yourself by improving too much because you have to continue to achieve significant improvement year over year. So know where those thresholds are and make educated decisions about what goals you are working towards throughout the year. And then finally, my last piece of advice is to invest in reducing disparities. Those social risk factors indicate some definite barriers for people with disabilities or low income, and getting programs in place to help those members close their gaps and achieve good health. Those are not things that happen overnight. So by investing in those members with with disparities, you can both maximize your health equity index and then also work on you're achieving significant improvement, right? Kill two birds with one stone there. Increase your rates for members with disparities can also increase your improvement measures because you're significantly improving your rates. So we covered a lot of information today, and the Star Ratings program certainly changes quickly over time. I would welcome you to download our calendar of star rating changes here to keep as a handy reference. And if you need help building a star strategy, Cotiviti tracks and applies CMS's updates to measures and weights in our Star Intelligence solution, helping our clients to stay ahead of that curve. So for more information about our Star Intelligence solution, contact us at answers@cotiviti.com. I'll pass it back to Cassie now so she can wrap us up. Thank you.
Thank you so much, Marge. So much information. As I mentioned at the start, this webinar is part of a year-long series we've titled Quality Decoded, featuring Marge and other experts from Cotiviti's Quality and Stars team. We kicked off this series earlier this year with webinars reviewing the 2025 CMS Advance Notice with Marge and the NCQA public comment that are both available on demand now. And Marge's webinar that we had today will be available next week on demand as well. Next, we have somewhat of an annual tradition for us coming up on July 18th, our end of HEDIS season webinar. If you haven't already, you can watch the recordings of any of these webinars you may have missed or sign up for any of those that are upcoming by scanning the QR code on your screen. Lastly, if you submitted any questions during Marge's presentation, your Cotiviti account team will follow up as appropriate. You can always send an email to answers@cotiviti.com at any time with additional questions or for more information. This concludes today's webinar. Thanks so much to our speaker, Marge Ciancetta. We'll be reaching out to you via email within the next week with a link to the on-demand recording of the webinar. And as soon as the session ends today, you'll have an opportunity to answer a survey about your experience. I'm Cassie Yazzo. Thanks for joining us again today, and we look forward to seeing you again soon.